Hey guys, oh, let me just turn the corner here. Okay. Hello there, you can see my face. Welcome back. This is our second live. I'm now on my way to Park Lane Hospital to do my pediatric MRI list that I've been doing for 2 years now. We do it every Wednesday with a great team. I'm going to introduce them to you when I get there. Guys, just two quick things. As I'm sure you can hear my voice, and if you ask the people who know me well, they would be shocked that it's possible that I am my voice is running out on me, but I'm pushing ahead, I'm trying. But the longer my sentences go, excuse me, you can hear that raspiness. So if you hear me clearing my throat, I apologize. And then secondly, guys, remember with these lives and all the things I do, there is a disclaimer, okay? I'm not providing direct guidance or a recipe for anyone to provide any anesthetic care or any other medical care. This is a guide. Consult your local textbooks, your local journals, your local professors, colleagues, and regulatory authorities. Okay, so now that the lawyers are out of the way, we are going to talk about a scenario that I also anesthetized at Baragwanath Hospital. So for my sins, I was not only part of the PEDS portfolio, the teaching portfolio, I somehow became the head of the obstetric portfolio, and by definition, the obstetric anesthesia. So Barra was one of only Joburg Gen or Barra that did cardiac pregnant patients in Joburg. And this was a 22-year-old young lady, a prima gravida, who was born with a single ventricle circulation with a tricuspid atresia, and she had a Fontan circulation. All right, guys, so what is a Fontan circulation? So a Fontan circulation, also known as a total systemic pulmonary venous shunt. All right, so what does it mean? Let's go back a few steps. I described to you in the episode 3 the classification of congenital heart disease, and we're going to look at tetralogy of Fallot. Number 1, in terms of complexity, it is the most complex, and immediately that'll take you guys back where I said that has to be done by someone like me, a PEDS cardiac anesthetist in a center that has not only cath lab facilities, ICU facilities, but bypass facilities if we have to crack open a chest and crash onto bypass. So then, in this instance, there is a tricuspid atresia. So she was born with a cyanotic congenital heart disease with a obstruction to blood flow. So therefore, she has decreased pulmonary blood flow. All right. So what happens is that when she was in utero, she would, the fetal circulation would ensure that the ductus arteriosus bypassed blood from the pulmonary artery to the aorta, and she didn't need really the right atrium or the right ventricle. Well, luckily for her, because she doesn't have a right ventricle. So now she's born, she takes a breath, oxygen tension develops, pressure gradients develop, and there's no hole in the heart here, remember, guys. So the chambers close, the PFO closes, and the PDA starts to close, and she starts to go blue and into cardiogenic shock. Why? Because a because a hypoplastic right heart or a tricuspid atresia, however you want to classify it, the end result is the same. Either the valve doesn't develop and then the ventricle, or either the ventricle doesn't develop and then the valve doesn't develop. Okay. So in these patients, she would start to go into failure. So she would have had what we call palliative shunts put in. The first one would be something called a BT shunt or a Blalock-Tausig shunt. And that is a shunt that connects the subclavian artery, most commonly on the right, but it can be on the left, doesn't matter, to, oh, my phone dropped, I'm so sorry. So what did I say, guys? A Fontan will connect the subclavian artery to the pulmonary artery in order to increase pulmonary blood flow. And if you remember now, guys, in all of these cyanotics, the final issue, whether it's a right to left shunt, whether it's an obstruction to blood flow, or whether it's just a good old-fashioned decreased pulmonary blood flow, the problem here, guys, is that they do not have blood going into the lungs, And therefore, the pulmonary arteries are these tiny little 1, 2, 3 millimeter things. They're not big enough. So you need to get the pulmonary artery to grow, number one. Number two, you need to get the child to grow by getting an arterial pressure source to force blood through the lungs. You then let the child gain weight. So the BT shunt can be done very early, within the first 6 weeks of life if necessary. It's often done for very large VSDs where there's been a very marked decreased pulmonary blood flow, as well as for tetralogy of Fallot. And we're going to go through in my lecture later this week, on anesthesia for pediatric open heart procedures. Okay. So then, guys, the next step after that is to do the Fontan, and it can be done either in a single stage or in a 2-stage procedure. And so the first stage is called a Glenn shunt. The second stage is called a Norwood shunt. And altogether, they make up a Fontan circulation. And basically, it's very simple. What often happens is that we create, number one, a common atrium. So the left and the right atriums are merged. So we create an artificial ASD. We then get total venous drainage for the entire body to passively enter the pulmonary artery, without needing to go through this non-existent right ventricle and atretic tricuspid valve. So the first step, the Glenn, is to connect the SVC to the pulmonary artery or the common atrium. And the second step is to connect the IVC to the pulmonary artery or the common atrium. So therefore, these patients get an increase in pulmonary venous return, but there is no ventricle pushing the blood. So I'm going to say that again. What is the definition of a Fontan circulation? It means that for no matter what reason the Fontan was done, the common answer is that the patient has only got a single ventricle circulation, and that ventricle is being connected to the aorta as a systemic ventricle. And so therefore, we need to get venous drainage into the right atrium and then into the pulmonary artery. So we do a Glenn and a Norwood, which altogether makes up a Fontan. What is the problem now? Well, when these patients need to come to theater, or God forbid go into labor or bleed after surgery, these patients are 100% preload dependent. So I'm going to say it again. They are 100% preload dependent, because if they don't get venous return, there's no blood going into the pulmonary vessels because they don't have a right ventricle. Secondly, they are totally unable to compensate for increases in pulmonary vascular resistance. So hypoxia, acidosis, hypercarbia, pain, fever, etc. They are not able because there's no right ventricle. So if the PVR increases, pulmonary blood flow automatically decreases and can decrease dramatically. The next issue with them is that central access in the upper body, in the subclavians or in the jugulars, is totally forbidden, because God forbid you damage the Fontan circulation. But what's good about these patients is that if you pump enough fluid into them, give them enough oxygen and keep their PVR low enough, you actually can handle them pretty well. So now that I've told you this, guys, I'm gonna let you think about it while I'm doing my list at Park Lane, and then on my drive home, or when I have a chance just now, I'm going to record another quick live just to give you the answer on how I did it and how she did. And while you're there, I'm going to do a second case study as a live while I'm driving. I love this. It's so much fun, guys. I hope you're enjoying it. Let me know in the comments and the likes, the subscribes, whatever, that you're enjoying this type of thing. So we're going to discuss that pregnant lady who came for her Fontan Caesar, and then we're going to discuss one of the most challenging and interesting cases I've ever done, and that is a patient with an with a Eisenmenger syndrome coming for a cesarean section. And that took everyone by the seat of their pants, guys. But I hope you'll stick with me, and I hope you'll enjoy it. Remember, like, share, and subscribe, comment. I'm on YouTube, and my website will be going live from this weekend. So please keep everything in mind. And I'm going to be on PayPal for subscriptions. So remember, Dr. Tristan Anesthesia Tutorials is everywhere. But please mainly follow me on TikTok and YouTube and Apple Podcasts. Thanks, guys.